Okay, I'm Ibrahem Hanafi. I studied medicine at the Master's University, graduated, and joined a specialization program in neurology in Damascus, but I quit. And now I'm studying a master program in translational neuroscience. It's a research program in Germany. Actually, I'm still working on some projects that are in Syria and working on some new projects here. And I don't feel like I'm an expert in statistics, but I've done the statistics for several projects in Syria and here, and I feel I can facilitate communication and we can get to a better understanding of statistics. Please tell me if everything is fine and if you can hear very well. Okay. Please do me a favor and ask as many questions as you can, because this is how we can communicate and we can get this course to a better level. We can't communicate like live, we can't communicate in person, but I suggest with so many questions we can keep it interactive, and this way is the best way to study statistics. Actually, I don't feel that anybody can teach anybody to how to read the numbers. Everybody of us needs to build his own understanding of statistics and of the numbers. So it's just facilitating each other work to understand the numbers, but it's not like teaching. Please interrupt me whenever you want, and if you don't want to like interrupt, of course you can just send a question to the chat. It will be easier to stick to English, but of course we can convert back to Arabic whenever you want. Please, confidentiality is very important. We will be dealing with different databases, and you will see a lot of data from different projects, and all of these projects are not published yet, and I'm still working on data analysis for them. So please consider the confidentiality of those patients. Of course, those some of those come from real patients, and some of those are from medical students, and so on. But everything is confidential. Even the idea or the concepts of the research projects, those shouldn't be discussed with anybody outside this group. Of course, to discuss whatever you want, whatever we are discussing here, and on the group and between each other, but is not in this. I would like if you introduce yourself to the group. Okay, I must go that we are really heterogeneous. Everybody of us has different experiences and different kind of skills. So some of us will see this workshop as the easiest workshop that they have been to, but please don't hurry, because we need to keep to the base of that person who is like the slowest or the one who has the lowest knowledge in that field. But of course, everything is optional. Whenever you want to join the session, please join, and whenever you don't want to, please just leave us. No offense, of course. The plan for today's session, it's never tense. We will start with different articles. For each of these articles, I will go through this process. We will go first to the tables. We will read the tables and figures even without knowing the title of this paper. Then we will go to the abstract, and for each one of these steps, you might get enough hints to know the methodology used in this article. So please, whenever you feel that you have enough hints, just send to the chat that you already have your decision and you know the design of this article, and we can go on with that. After that, we will assess the strength of association that is done in this paper, then the risk of bias, and we will place it on the hierarchy of evidence-based medicine. Okay, what is the objective of today's session? It's actually to understand the research methodology that is used in each of these papers. We will cover nearly most of the research articles that you can read. Of course, there are some articles that are really complex and we won't cover those, but we will cover the main types. For the course objectives, that will be defined by this session, because when we are going through the tables and figures, we will understand that, okay, we have this relative risk, we have this odds ratio, we have this confidence interval, and we need to understand those numbers. So today we will define the terms that we need to understand in the coming sessions. So please don't forget to just send to the chat whenever you feel that enough hints have been presented already. Before we start with the papers, I suggest we revise the BICO. BICO is the most important thing in research methodology. Whenever I want to go and read a paper, I need to understand what is the BICO of this paper. And whenever I want to do research, I need to understand the BICO of the research I am going to do. First, the patients. The P in the BICO stands for the patient. What are the specific characteristics of those patients? What is the disease they have? Sometimes they are not patients, sometimes they are medical students, sometimes they are elderly people. Any option is possible. Second is the intervention. I stands for the intervention. What is the intervention I'm going to do? It can be diagnostic, like I'm doing a research criteria or a diagnosis criteria, and I need to just test it or validate it. So this intervention is just a diagnosis criteria. It can be an intervention that is harmful. It can be an intervention that is harmless or helpful. The C stands for the comparison. Not every paper had this, okay? So please understand that we don't have to find everything, all the BICO, but the most we have, the more we will understand. The comparison can be another intervention, for example, another diagnostic criteria, another drug, a placebo, doing nothing, the golden standard, anything can be compared to the intervention we are doing. The outcome. Okay, I'm doing an intervention, but what I'm searching for, is it a fatality? Is it mortality? Is it a treatment? Is it like how many episodes of headaches that person will have? And the type of question and the type of article are the last. So we can start with the first paper, and I can background introduce the gap of knowledge this paper is going to fill. Okay. 2, we have case 1, and we have here description of something we don't know yet, and we said we're not going to read any text. We are just going to read the figures and the tables. Figure 1, bone marrow aspiration for case 1. Figure 2, bone marrow aspiration for case 2. We are reading CR1. You can see the title here in the middle. Yeah, thank you. Okay, then we have case 2, and altogether we are going to the discussion. So we don't have any tables, but here we can find a table. What is this table for? Please send me if you already get the answer. What is this paper about, or what is this study design of this paper? Or just unmute your phone and your mic and tell us. Table 1, diagnostic criteria for macrophage activating syndrome. Table 2, diagnostic criteria for macrophage activating syndrome. Another diagnostic criteria. And here we have the just continuation of the discussion, the diagnostic criteria, another diagnostic criteria, and the conclusion. So I think this is a case report of 2 cases, and actually this is right. We can go back to the title and we can see that it is a report of 2 cases and a literature review. Now we understand they have tables, but those tables are just to report the literature search they already have done. Yeah. But they didn't find out anything in these tables. It's just like a reference from another. You can see here a reference from Baroudi paper. So those tables are not the results of this paper. And so what are the results of this paper? It's just case 1 and case 2. It's a report of these cases. And to understand what case reports are, sorry, what are case reports meant to be?
That are mentioned in the reference, but the case report, I think the purpose of it is this syndrome is rare. It's good to publish it and make doctors know about it.
Exactly. This is what case reports are meant to do. And actually, let us just decide what are the main interesting thing in these 2 cases. We can find it at the last line of the introduction. One of the 2 patients is 4-year-old. She is the youngest reported patient of juvenile SLE manifesting a macrophage activating syndrome ever. So this is what is special about one of these 2 cases. And in the line before, we can see that in this report we describe 2 cases with their clinical manifestation, laboratory data, and management. So those 2 cases are special because they have macrophage activating syndrome as the first presentation of SLE, and this is not so common. And one of these cases is 4-year-old, and this is really young. Those 2 reasons make this paper publishable. What can make another paper publishable? It can be a new syndrome, for example, a combination of 2 diseases that haven't been reported before. But it should be connected to each other, or there should be something like clinically relevant to somebody. If I'm going to publish this paper, I need to send it to a rheumatologist, ask him, do you feel that this is clinically relevant? He might say yes, and he might say no. Okay, so this needs to be discussed with the clinician, because the case reports are not statistical. There are no numbers, there are no reports. It's just those cases are SLE and they have macrophage activating syndrome. So is that important for a rheumatologist? We ask him and he says yes, and we can publish this paper. It can be an intervention that is unusual. It can be a side effect unusual. Anything that is not usual that needs to be reported, we can report it. It can be like the death of one of the patients because of the side effect of some kind of intervention. Is there any association in this paper? I don't think that there is any association. It's not linking anything to anything, okay? But is there any risk of bias? For the risk of bias, there is a lot of bias in this paper, but we can't say that a case report has a risk of bias because we already know that, okay, I don't know. Please, do you feel that? Urge me to write any reference that I don't want to, and it is all made of bias. So there is no risk of bias because it's all made of bias. Okay. So where does it stand in the hierarchy? Actually, it stands at the lowest level. Here we have, of course, the expert opinion or any editorial. Those are actually just opinion. Case reports are higher than any expert opinion because those are real cases. Of course, when an expert opinion is built on a randomized controlled trial or a systematic review, it's really high. But when we are saying that I suggest as an expert, as a clinician, that this disease won't be treated by this intervention, this is really low if it is not based on anything. So for case reports, why does it stand here? Because it's a lot of bias. There's a lot of bias in these articles, and we can't prove that if we do another intervention, would it be better? Would it be worse? What would it be like? So we just ignore this case reports when we have any other articles from the highest level. Okay, we can move on to the second paper. For this paper, we have no table, introduction, case presentation. We have a CT, compute demography, at diagnosis. We have those biopsies. It seems like biopsy, it's liver biopsy. Okay, for this, we have a table here, hopefully, and we are going to collect some hints from here. We have physical aspects. How much were you able to accomplish? It's like a questionnaire, and we have here before treatment, after treatment. Do you already have any clue? What is this paper about? We have here another CT, compute tomography, after the last cycle of chemotherapy. And we are saying that compute tomography imaging 3 months, and we have all these pictures. We can't say that those pictures are from different patients. So we have that clue that this paper is talking about one patient. And if it is reporting one patient, then it is like
a case report.
A case report, another case report. So, but what was special about this was how many metastases this cancer had. So this is actually an interesting point. One cancer with 7 metastases, as I remember. Okay, we can move on. We will go to CR3. As you can find, we can decide on the research design or the methodology of the paper just from the tables. Okay, so for this paper, we will just go, we have here methods, we have like intervention, and intervention is reported here. We have some figures here. intact cyst in the left lung. Here we have ruptured cyst. Okay, they seem like sampled. That there are many pictures, and they are saying that because when we have ruptured cyst and we are not saying when it was ruptured, we know that this ruptured cyst is not the same as this intact cyst. So we here have the results, and in the results we have a table. In the table you can just find the number of cases, males, females, total, lung involved, clinical type of the cysts, and each of them has just a number and a percentage. And do you feel that you have any clue already?
Case series, maybe.
Case series, exactly. We will see here another, yeah, exactly. Another table that says results of various studies of VATS, which is the intervention, I suppose, for pulmonary hydatid cysts. So we here have different studies, and those different studies have different numbers of patients, different ages, different outcomes. Okay, but this table, I suppose, is related to the discussion, because in the results we can say that we have this paper which is referenced here, and these results from this paper, this should be in the discussion, okay, or in the results of a systematic review, and we are going to discuss that. So from the tables we understood what is the methodology of this paper, and we can go to the title to see that a video assisted thoracoscopy surgery with mini thoracotomy for the management of pulmonary hydatid cysts. But this title actually doesn't say what is the methodology of this paper. This is unlike the other two papers we already read. So I'll go to the methods. Okay, for the methods we have here, we reviewed the medical records of patients who underwent unilateral and bilateral surgery, single pulmonary hydatid cyst excision using VATS. Okay, so we have many patients, and those patients are in the past. Okay, but do they say that they assessed the patients afterwards or before? No. And actually, we can do a cross-sectional in the past. Okay, then what should it be? It feels like a case series, because we have those 100 patients, or I don't remember the number, but those 100 patients, they were underwent a surgical procedure in the past, and we went to their records, we recorded that, and we reported in a paper. Do you feel that is it contradicting with any other information you already have?
So in this paper, because I didn't read it, in this paper you didn't do any comparison?
We didn't do any comparison because we only have one group. We only have those patients with the same case, and every one of them has undergone the same procedure. So we don't have anything to compare in between.
So it's just reviewing the intervention?
Exactly. It's a reporting a new intervention, actually.
Okay.
Okay. So here we don't have any comparison between two groups. We don't have any longitudinal assessment. We didn't assess them after surgery or before surgery. We didn't contact them. No, it's just we went to their medical records. We knew that those patients underwent these surgeries, and this is actually rare, or this procedure is new. So we went there, we collected them, and we reported them. And this is a case series. It can be from 100 patients to 3 patients. Anything of those can be a case series.
Can we see any tables in this case series?
In the case series, we can see a table, but look, this is the table we have. It's just reporting the characteristics of these patients.
That's it, okay.
And the other table is reporting other studies. So it's not relevant because it is belonging to the discussion. We just need the tables that are reported in the results. Okay, so this is a case series, and we are done with the easy part. And now we should go to a more difficult part. Okay, let's go to CS1. For here,
Okay.
we have the abstract, we have introduction, we have methods. We don't see any table here. We have a table. Okay, on page 3 of CS1, we have a table. And this table is actually similar to the last table we saw. It's gender. Here they are saying that they have 323 participants, and this table is for the general characteristics. They are reporting the year of study, the gender, internet connection status, English language skill, and everything. They are just saying the number of participants who have this characteristic and the percentage. Okay, that's fine. Then it can be a case series, but it can be cases because those are participants, not patients. Here we have another table. For this table, you can see importance of research. And when we have this indent here, if you see that space here, then those lines belong to the first line. Okay, this is how we read tables, and those lines belong to barriers of research. So for the first line, we have this question. We have the total number. We have strongly agree, disagree, neutral, agree, strongly agree. Okay, do you have any hint what can this study be? When you see a number and another number between brackets, it is the percentage. You can see it here. We have a number and a number in brackets, which is the percent of this paper out of the whole group. Okay, it's actually a cross-sectional study. It feels like those are questions and those are the degrees of agreement of those participants with those questions. Let's move on to another table. Here we have importance of research. Same. Here we have agreement from basic sciences, agreement from clinical years. So those are the old participants, those are the young participants, and we have the numbers of them, and we have a p-value here. This is the first time we see a p-value. Then here we have a comparison. But what is this comparison between? It is comparing between two groups of the participants we already have, the younger group and the older group, and they are comparing them. Do you think now that this is contradicting with your decision that this is a cross-sectional? Do you feel that comparisons shouldn't be in a cross-sectional, or it can be? Okay, I'll move on.
I guess it can be.
Sorry?
Yeah, it can be, I guess.
It can be, actually.
Yeah.
I'm doing a cross-sectional. What does cross-sectional mean? I'm going to some participants. I define that I'm going to the Faculty of Dentistry, and I'm going to ask those participants a sample of questions. And then I thought that those who are in the practical years, would have different answers from those who are in the basic years, and I compared them. This is okay. We do not change the methodology of the paper because we just compare two groups. It is still, I'm going to them at a single hour. I'm asking everybody the same question, and this is the definition of a cross-sectional.
Yeah.
Okay, here we have a percent of participants who reported these outcomes, and here we have experience of participants regarding research, who did some research, who didn't, 1 project, 2 projects, 3 projects, and they go on. Here we have a comparison, another comparison. What is this comparison between? Can you see it? Can you say it, please? Just read the title of this paper, of this table. Association between participants in research project.
I just want to ask you.
Of course.
So before collecting your data, you put the comparison. You decided your comparison. So what
before you collected it?
Before collecting the data, or it depends upon the data you have collected and upon your observations. So
actually, I can expect the comparisons I'm going to do, but of course, I thought that the practical years will have a higher agreement in comparison to those in basic years. But when I did the test, they are not different, and the difference is between males and females. So I totally changed the comparison, and this is okay. Actually, the most important thing that I go to those participants at a very single moment, and I collect the same data from everybody, and I don't follow up, and I don't go in the past. If I do that, then I'm going a cross-sectional study.
Yeah, but in your
I'm going at the same time, but I can, like, after I collected the data, I decided I would go for a comparison between those and those. After I published the paper, I decided that another comparison should have been done. So it is okay. We can do the comparison whenever I want to, but the most important thing that I can't collect a new collection of data.
Okay. I have a question.
Yeah, of course.
Yeah, when I do cross-sectional, sometimes I ask the participants about any questions, but I put others. So maybe from others, I can specify a specific difference that I may not notice in the beginning. So I will go back and ask the other about this factor before I consider it, right?
Yeah, of course. Yeah, that's okay. But when I go to him, I shouldn't ask him. For example, if I'm asking, "Are you happy?" and I lost some data, and I went back to him. "Are you happy now?" No, it shouldn't be like this. When I collected the data?
Yeah. Okay.
This is the important thing. Actually, it shouldn't be done like this, because this introduces some kind of recall bias, because sometimes he do not remember if he was happy or not. But if I'm asking him, do you have any malignancies in your family? It wouldn't change. If I'm asking now or 1 month ago, it is okay. So we just need to understand that it should be at single hit.
Yeah.
Okay, so let's return to this table. Does anybody have any clue what they are doing in this table? Table number 5.
Looking for any association between each characteristic of the participants. So they made like subgroups, and they trying to do connection.
But connection with what?
With the research project.
Research يعني
Exactly.
research papers.
Okay. And here we go to the the fifth line. What is the strength of association here? Okay. Actually, here we have association. It is saying that we have associations between groups. And what is the certainty of association that we have? If I'm saying that those participants in their second year, in comparison to those who are not in the second year, they have more research projects than any other participants, for example. Do I have a strong association? Can it be a strong association? Actually, I'm asking them at a single point. It can be the association is those who are publishing, okay, are in the second year because of something else, something confounding, some other factor. For example, those in the second year have another professor or a new professor who is telling them how to deal with research. Okay, if we move to another one, for example, English language skills in writing. Okay, we can say that those who have English language skills do medical research, and we can say that those who do medical research need to understand, need to train more on academic writing. Okay, so we have association, but it can be either ways. Do you agree?
We can't decide which one is the cause.
Exactly. We have
The other,
association, but we don't have causality.
Okay.
Okay.
Thank you.
Actually, causality have several degrees, and this is the lowest degree. First, to do the causality, first we need to know that there is association. But now we will move on to more complex studies, and there we will understand the highest levels of causality. Okay, here we have experience of participants regarding writing and publishing in scientific papers. And this is actually just reporting the numbers and the percentages. And actually in this paper we have a lot of tables, and we could understand the methodology they used from the tables. It is actually searching for the attitudes and barriers towards research and publication among medical students. Okay, so it's really easy to understand the methodology and the methods. It's a cross-sectional study using a questionnaire, self-administered. Okay, it's really easy to understand the methodology just from the tables. And actually, when I read a paper, I usually just read the title and go directly to the tables, because this is the easiest way, or not the easiest way. It's hard, but it's the fastest way. Okay, please just tell me if we are going like fast, we can slow down.
No, it's great for me.
Okay, so we will move on. We will take another. Okay, is there any risk of bias in the paper we already had? What do you think?
The way we chose our participants, maybe.
Of course, selection
Or
bias.
the data you included, is it all the data you collected, or some of it?
And this is actually reporting bias. But for this reporting bias, you don't know if I'm reporting just part of my data unless I published a protocol in advance. If I have a protocol and you know that I already collected data from 600 participant, then you know that now I'm just reporting 400. Then there are 200 that I skipped. Okay, but actually I turned off the screen sharing to just explain this. But we have risk of bias. We have recall bias. Recall bias is that when those participants do not remember, I might have participated, and now we are recording. Okay, so we will go to the title. So, yeah, please.
What is the second option?
Actually, it can be a controlled trial. And this controlled trial is when I am deciding who will get this intervention and who will get the other intervention. And the other option is a cohort study when they are deciding their interventions. Okay?
Okay.
Okay. So we will go here and we will read the title, Perioperative Liver Function After Hepatectomy, International University Hospital in Damascus. The method, until now we don't understand what is the methodology of this paper, and we need to understand. We couldn't get the idea from the tables. Between 2009 and 2016, 100 patients undergoing liver resection in Damascus hospital. We performed with division into anatomic and non-anatomic or malignant with non-malignant groups. So they are saying that they compared the groups, but they are not saying that they divided the groups. So it's not a trial, exactly, Basel. It's not a trial. We are not deciding. It can be a trial if they said that we divided the participants two groups. One group will take anatomic resection and the other group will take non-anatomic resection. And now we have our answer. It's a cohort study, but there is types of cohort studies. When this paper is published in 2017, and they are saying that between 2009 and 2016, so this is really old, those patients took this intervention. Okay, so exactly, it's a retrospective cohort. Why? Because they went back actually and followed those participants, but forward. We can't say that those participants were followed retrospectively. Actually, it is a cohort, and when we are saying it is a cohort, then it started at one point and continued in the time forward. Okay, so they went back to 2009 and followed the patient forward, and that's why it is a retrospective cohort. And now we can move on to another study. We can take RC2. Why not a case control? And this is actually a very important question. Okay, why is it not a case control? Actually, when we have a case control study, we have two defined groups. Those groups should be the first group have the disease and the second group doesn't have the disease, and we have that thing in advance and we follow them back. Usually case control studies are going retrospectively, but what is the difference between retrospective cohort and the retrospective case control? They said that they went and collected all the patients who underwent this resection. And when we are saying that they collected all those patients, then they are collecting a cohort of patients. But when we are going that they went back and they just took a sample of those who underwent anatomical resection and a sample of those who underwent non-anatomical resection, then we can say they did a case control study. Some of them are cases and some of them are controls. But they didn't. They went back, they took everybody in between those 2 years and followed them, and some of them had the intervention of anatomical resection, and some of them had the other direction. And how do we know that? Because the number of participants in each group is not the same. They're not equal. Does that answer your question, Ahmed? Okay. Concordance between epidermal nerve fiber density and sensory examination in patients with symptoms of idiopathic small fiber neuropathy. Okay, for this paper, I'm going to see what are the tables. Here they are saying that the epidermal nerve fibers density are different between different groups. Normal beam break is a test for neuropathic pain. They just put a pin on the skin and test for pain. So here we have different ranges for different groups for this density. And here they are reporting sensitivity, specificity, and positive and negative predictive value. Okay, and actually this is new. When we are saying that they are testing sensitivity, specificity, then it is a diagnostic study. And till now, we know that they tested that in skin biopsies, and it is diagnostic. If you have more hints, just tell us. If we go to the third table, they are saying that, sorry? Okay. This outcome, if it is below 8 or above 8 with abnormal pain, they are just combining those two variables, this continuous variable and this categorical variable. And they are saying that the sensitivity and specificity for this association is somehow different. Okay, here they have another sensitivity specificity. Here they also reported the outcomes for those groups, and nothing new. And here we have correlation. When we see that line and those cases distributed around the line, then it is correlation between that fiber density and the density in the foot. Actually, the density in the calf and the density in the foot. Okay, from the tables, we do not have any other clue. Okay, so we need to read the methods. If we go here, for a diagnostic test to be clinically useful, okay, so if the abstract is not categorized into background methods, and so I suggest we go directly to the methods. Okay, medical records of all patients referred to the University of Minnesota, okay, between November and July 2005. Does that answer our question? What should it be? Actually, cohort retro again. Actually, this is an excellent answer. They went back retrospectively to those records for those patients between those 2 years and collected the patients. And for those patients, they said, we divided them into different groups. We say that the density of those groups are different, and they tested for the sensitivity and specificity of different tests for their outcomes. And why is it a cohort? Because they collected one group of data, one group of participants, and they have one a collection of outcomes. Okay, so this is really similar to the last paper, and we couldn't know from the tables what is the methodology of this paper, but it was really clear from here, from the methods section. So do you have any question before I have one question for you? Okay. When do we know that we have a cohort study? When we have one group of participants. Either they are collected right now. If I go now and collect everybody in my city and tell them I will just follow you through time and see who will have a heart attack. This is a cohort study. Why? Because I have one cohort of participants, and you will now see the difference between a case control study, actually it is already said here, a case control study and a cohort study. Okay, we will go, I suggest we go to the methods directly. To evaluate further a possible association between aspirin use and risk of pancreatic cancer, we use data from population-based connected study conducted from January August of 300 pancreas cancer cases frequency matched to 600 randomly sampled control. And here you can find the difference. We already have two groups from the very beginning, okay, at the hospital, okay? So for each patient, we can have several controls, but we can't say that we have patients, but we don't have controls. Depend on the prevalence. Actually, I'll talk about the prevalence in a moment, but just for now, you can see that we already have two groups. Okay, we will go to the table. If we have tables.
No, it doesn't have table.
It has table. Look, it is
in
the 12th page.
Page 12.
Yeah.
Oh, yes.
Okay, here we have the characteristics, and you can see that they can't mix the two groups. If you remember from the last study we read about hepatectomy, they reported in one table all the patients altogether. Then they said for those who underwent the first intervention and for those who underwent the second intervention. But first, they could merge them. Here, they can't merge them. They can't say all participants had a mean of age that is like this, okay? If we go on, here we have three groups of those patients who took aspirin. Okay, how do we understand why is it a case control with another method? Okay, if we say that we are going to test if aspirin is associated with pancreatic cancer, we have two options. I go to a group of patients who are taking aspirin and see if they are developing any pancreatic cancer. This is the first option, and this is called a cohort study, right? Okay.
Yeah.
The second option, if I go to those who already had pancreatic cancer and I ask them, did you take aspirin or not? Okay. If I do this, it is a cross-sectional study. Okay, because I just went to those who have cancer and I asked them, did you take aspirin or not, in a simple question. at a very single moment.
Yes.
But if I want a higher evidence, but I don't have the funds that are able to make me take a whole cohort, I will go to those who had pancreatic cancer and I will ask them, did you took aspirin or not? And I will go to another group of controls who do not have pancreatic cancer and ask them if they took aspirin. But those control group should be matched to the cases in their ages, in their gender, in their homes, in their cities, okay? So what does that mean? If I'm taking a group of cases and a group of healthy controls, and I'm saying, did you took aspirin or not? This is actually a case control study, okay? What is the benefit of case control studies on cohort studies? If I tell you that those who take aspirin will develop pancreatic cancer in 50%, for example, it's easy to have a cohort of those people who are taking aspirin and see if it is 50% or 40%, right? And this is easy to do a cohort study. We are searching for the sorry?
It will reduce the bias.
It will reduce the bias because now I know that those participants are taking aspirin and I will see when the cancer will develop, and it is really high, it's really cool. But if I tell you that just 1 per million of those who take aspirin will develop pancreatic cancer, will you be able to take a cohort of 10 million people just to get 10 patients with pancreatic cancer? This is actually illogical. And what is the solution for this? Okay, I go and collect those patients, those 10 patients who already had cancer and those who took aspirin, okay? Mostly, for example, we have 10 cases, but just 9 of them took aspirin, okay, and that is fine. And we select a group of 10, 20, 30, or 40 controls, and we ask them if they took aspirin or not. If I see that 9 of those who had pancreatic cancer did take aspirin in the past, and for those who do not have pancreatic cancer, just 5 of them took aspirin in the past, I understand that aspirin is associated with a higher risk of pancreatic cancer. Do you agree or not?
Well, yes.
Okay, so I just need an answer from Ahmed if this answered your question. And I think I answered your question, Maya, about the meaning of why do we use case control for rare cases?
Yeah, you answered my question, but the other question, so how can I decide how many controls I in comparison with the cases? So for each case, I need 1 control, 2, 3, 4. How can I decide that?
Okay, the more controls you have, the better. You just need to decide when to stop. Okay.
But there is no rule or no calculations for that.
Actually, they say the hardest thing in medical research is to choose the controls. For example, I can say that I will need the control who is a brother of this patient, but this brother lives in another city. So can it be a control anymore? I don't know, actually. If I say that the control should be in the same room in the hospital, but it can be a contagious disease, and those patients can transmit the disease to their neighbors in the hospital. So it can't be a really good control. We can go to another control, for example, the parents, but the parents are not matched regarding age. So searching for a control is a really hard thing to do. And for each case, you will need to decide how many controls you need. Would you multiply the controls in regard to the cases? Would you like to take less controls? Would you like to take the neighbors as controls? For example, my control can be the person who is living in the room beside me, okay? Because he has the same risk factors I have.
Won't we be biased in here?
Of course. For
I
each
mean,
one of
when
those
choosing
controls, there will
controls.
be a bias.
Okay.
Yeah, and the bias for these different groups of controls will be different. For example, as I told you, for each group of controls, we will have different bias. But what do I do when I have different controls? If I have 3 controls and the comparison with the 3 controls is positive, then I reduced the risk of bias, right? Because okay, if I have a group of cases and I took one group of controls, I will have a risk of bias, and you can see it. But if I took, instead of 1, 3 groups of controls, and the comparison with the 3 of them is positive, then you can see that it is important even with the bias. Is that right? Yeah, thank you, Basel. We didn't match to controls. We just split the group we had, right? Yeah. Actually, Ahmed, for the last paper, we didn't divide. They were divided. I went to them. Exactly. The more controls, the more power of evidence. Okay. For the last paper, when we took a cohort study, we took the cohort and we found out that some of them had some intervention and some of them had another intervention. Such as when I go to my city and I find that 10% smoke and 90% do not smoke. This is their decision, and this is still a cohort. If I compare them, it is still a cohort. But when I say that I'm just collecting depending on the outcome, as Basel said, I'm going to take the cases and compare them to some controls who do not have that disease, then I'm doing a case control study. Okay, what are the benefits of a case control study on a cohort study? Is that it doesn't require a lot of funds, because I'm just taking small groups of participants, and I can ask about everything in the past, actually. So I have one outcome, which is the disease. I have pancreatic cancer and non-pancreatic cancer, but I can ask about 1,000 risk factor in the past, okay? And this is really cool because I can define everything that might have contributed or have a significant contribution to pancreatic cancer. But what is the benefits of cohort studies? Actually, the cohort study, I have a higher level of causality because I see the patients and I see the disease or mortality or anything that is developing. Okay, so the level of causality is really high. requires a lot of funds because I'll need a lot of patients, a lot of people to collect the data and so on. But what is the most important thing in cohort study in comparison to case controls? I have one exposure and I can collect 1,000 outcome. How? For example, if I go and collect the cohort who are, for example, rheumatoid arthritis patients in my hospital. I went to them and I collected everybody there. I can report everything in the future. I can say some of them are dead, some of them had pain, some of them had headache, some of them did something else, okay? So for cohort studies, I have one condition, I define the group depending on that, and I can take how many outcomes I might need, but for case control, I have one result and I can ask about every exposure I might need. And this is the most important thing. Okay, if you are fine, I can continue with the paper. Okay, here we have a comparison for those regular aspirin, low dose aspirin, any aspirin. Those are three groups of the patients. They are not comparing them to the okay. Here, look, inside the column they put the controls. So I just read the title and I didn't understand, but here they reported the controls inside the columns. Okay, do you need anything else from the tables to understand that this is a case control study? For example, in here, the odds ratio, they are saying that pancreatic cancer odds ratio for individual either regular using aspirin during specific time interval in the past. So they took those patients with pancreatic cancer, they asked them about the dose of aspirin they took in the past, and they took the different groups of controls and asked them the same question, and they compared them and reported that here. Okay. So I feel that this paper is done. Okay, so just let us talk about the strength of association. When I have a case control study, I have association and it's higher than a cross-sectional study because we have less bias. I have the cases now and I'm asking them about the past, about their exposure. It's higher than I'm saying that those who know English are working on medical research. Okay, but the highest association, can we read the OR? I'd like you to take a note of that because we will have another lecture just about the OR. Okay, but what is the higher level of association? When we have a cohort study, I have a group and I see the disease developing. The risk of bias, we have a higher risk of bias for case control studies in comparison to cohort studies. Why? Because for case control studies, I have to decide on the control group, and it can be really good and it can be biased, and this is kind of selection bias. If I go to a cohort and I go to my city and I take everybody, it can be biased. I'm not anywhere. If I go to a city and I see how many heart attacks I will have in this city because they had a bomb or something like this, they had a stressor, so I can't be biased because I've taken
But
the whole cohort. Yeah, please.
But the effect of bias control will be much more than the effect of bias in cohort. It
Exactly.
will affect the result much more.
Exactly. And that's why you can find here, you can see here that cohort studies are higher than case control. Because here we have a lot of bias in deciding on the control. Here we have the control inside the cohort. I took the cohort and inside it I have everything. And it is actually representative of the community. Okay?
A cross-section study should be at one point of time. But can we do it through a period of time? Like if I want to study the recurrent pregnancy loss in women in Syria, can I go back to the data of women, see the hospital during last 5 years?
Okay, let us discuss the different options you have for this study. Okay, you are going to the miscarriage, right?
Yes.
Okay, you have different options. First, you can go to the hospital and ask every woman in the hospital of gynecology about this, about their previous miscarriages. Okay, and this can be a cross-sectional study. Of course, you can go for 3 or 4 or 10 days because you have a lot of patients, but you can't go for the same patients on Sunday and then go back on Monday, because that will be 2 assessments. Okay?
Okay.
That will be when we have 2 points. But we are talking about the patient, it's not about you. So if you are going at 10 days, but you are approaching the patients, each one, just at one moment, then it is a cross-sectional. It's not about you, it's about them. So for this, we have the cross-sectional study. Then we will have the option to go to the records and see for each patient how many miscarriages they had. Okay, and this can be actually it can be a case control, those who have miscarriages and those who do not have, and you go to them and ask them about their history. And it can be a retrospective cohort. You go to the patients, you take a cohort of patients, for example, you go back to the year 2017 and take everything there, and then you classify them, those who had miscarriages and those who do not, who didn't have miscarriages, and compare them. This can be a retrospective cohort. It can also be a prospective cohort, right?
Okay.
Okay, so you have every option.